Bismillahirrahmanirrahim. First, I want to thank Dr. Hisham Al-Ghazali and the organizing committee for this nice meeting and for inviting me to present my lecture. Management of Lloyd's tumor of the breast, NCI study. First, I will show the points that I will talk about. Aim of the work, results, epidemiology, and clinical presentation, radiological investigations of the patients, and treatment algorithm for proper management of Lloyd's tumor of the breast, and the treatment modalities of our patients. And I will show the post-operative morbidities and mortalities, and I will show the pathological subtypes and recurrence, and recent guidelines to avoid and to treat recurrence, and last conclusions. Then this study was carried out to review the surgical management of Lloyd's tumors of the breast in the National Cancer Institute during a period of 5 years, 2005 till 2010. Our study including 32 patients. We have 60% were benign disease, and 25% were borderline tumor, and malignant tumors was seen in 15% only, and the median age of the study population was about 45 years. Lloyd's tumor account for fewer than 0.5% of all breast malignancies, and so epidemiological data are scanned due to this rarity. In our study, the site of the tumor was observed in the left breast in 62%, the most common type, and was seen in 28% in the right side, and bilateral disease was observed in 9% only in the patients. Regarding the radiological investigation, the most common tools were used in the patients and in the diagnosis of Lloyd's tumor were breast ultrasonography and mammography, breast ultrasound showing hypoechoic lesions, and bone scan was done in 2 cases of malignant disease in patients complaining of bony pains, and CT chest was done in 9.3% of cases in suspecting of pulmonary metastasis. The biopsy, regarding the biopsy, the core needle biopsy is the most common type used in our patients, and it's the preferred method for diagnosis. A core needle biopsy can give 30% false negative rate, and so excisional biopsy should be performed if the core biopsy is intermediate, and it will be necessary to make the diagnosis. Regarding the surgical approach, a surgical approach including a wide local excision with histologic margin negative for malignant cells. Other studies suggest a histologic margin of at least 1 centimeter, which is much larger than what's required for invasive or in situ breast cancer. This slide showing a simple teaching for proper diagnosis and management of Lloyd's tumor by clinical examination, by history and clinical examination, and breast ultrasound and mammography. You will, followed by excisional biopsy, you will determine what the pathological type of the tumor. It's a fibroadenoma. It will be observation. It will be the case will be under observation after the surgery. In benign and borderline malignant disease, wide local excision without axillary staging, and invasive or in situ cancer can be treated according to the protocols. This slide showing the treatment modalities that were used in our study. And lumpectomy, wide local excision, was done in 78% of our study group, and modified radical mastectomy was done in 12.5%, and simple mastectomy was done in 9.3% of our study. And oncoplastic breast reconstruction and contralateral reduction mammoplasty was done only in 3% of our study group. But regarding the pathological subtypes and the gross picture of the phalloid tumor are characteristic: round, oval, multinodular masses with grayish-white appearance and resemble the head of a cauliflower that may be indistinguishable from fibroadenoma. Phalloid tumor grow radially, creating a pseudocapsule through which tons of stroma may protrude and grow into adjacent breast tissue. In our study, positive margins after surgery were detected in 2 patients only, 6% in the surgical specimen, and the remaining patients revealed negative margins. Regarding the positivity of lymph node affection in the surgical specimen, we noted 1 case only showing positive lymph node in the surgical specimen. In our study group, we have not post-operative morbidities, and we noted 1 case of mortality. This case showing bilateral pulmonary metastasis in a case of malignant disease, and the patient died from respiratory distress and failure after admission to the ICU unit, and the mechanical ventilation was used. Regarding the adjuvant and neoadjuvant therapy, neoadjuvant chemotherapy was not noted in our patients, and no case received neoadjuvant therapy. And adjuvant therapy, we have 1 case received adjuvant chemotherapy in the form of 6 cycles of FIT, and 2 cases received adjuvant radiotherapy. Adjuvant radiotherapy for breast phalloid tumor is controversial, and some data suggest that adjuvant radiotherapy should be considered for patients with histologically malignant disease, as observed by Samorova et al. 2004. Hormonal therapy is not effective for phalloid tumors, despite the presence of positive hormone receptors in the epithelial component of some of these tumors. This table showing the sites of metastasis in patients at presentation, and we have 2 cases only. We have a case of lung pulmonary metastasis in a case of malignant phalloid tumor, and 1 case of lymph node metastasis. Regarding post-operative recurrence, the recurrence showed and occurred in our study after surgery in a period of 7 years up during the follow-up, and the recurrence occurred in 9 cases only. The type of the sites of recurrence, as shown in this table, we have 7 cases observed and presented with local recurrence, and 1 case presented after surgery with pulmonary metastasis, and 1 case with bone metastasis only. This table showing the recurrence according to safety margin. We have 7 cases with loco-regional disease with negative margins, with loco-regional recurrence with negative margins after surgery, and we have 2 cases with positive margin have loco-regional recurrence. This slide showing the recent NCC guidelines 2013 in proper management of local recurrence after surgery in cases with phalloid tumor, also by history and physical examination and breast ultrasound and mammography and tissue sampling biopsy. We can differentiate between metastatic disease and non-metastatic disease. In cases of metastatic disease, metastatic disease management following principles of soft tissue sarcoma, and in non-metastatic disease, NCCN guidelines recommended for re-excision and wide margins without axial staging, and consider post-operative radiation. Conclusions. Different surgical modalities are considered the main line of management of fluid breast tumors. Wide local excision means excision with the intention of obtaining surgical margins more than 1 centimeter. Local recurrence in non-metastatic disease can be treated with re-excision with margins without axillary staging and consider post-operative radiation. Metastatic disease of breast fluid tumor should be treated as soft tissue sarcoma protocols. Thank you.